Welcome to the webinar about using the sniper technique in central venous occlusions. My name is Marcelo Guimarães. I'm a professor of surgery and radiology at the Medical University of South Carolina, and it's a privilege to host this webinar. I would like to thank Bailey's Medical for the opportunity to share our experience with this technique. So it is well known that most of the central venous occlusions, as you can see here, can be treated with conventional balloon angioplasty, and in most cases, even severe occlusions that have severe and long occlusions can have venous remodeling after balloon angioplasty, as you can see in this case. In some venous stenosis with recoil effect, stenting may be required. However, we know that up to 25% of the conventional techniques to recanalize intravenous occlusions may fail. So in the last 15 years, we have faced challenging situations with patients with history of failed attempt of recanalization of central venous occlusions. As you can see here, some of them very symptomatic patients, either with facial swelling or upper extremity or lower extremity. And we have developed, in order to address this population who had failed attempts of recanalization of central veins somewhere else, we have developed a protocol for the management of this complex patients. First criteria, because of the potential risk of complications, we only use this technology after failure of standard angioplasty technique using conventional devices. The second criteria is the patient must be symptomatic or have a malfunctional dialysis access due to a central venous occlusion. So all patients are evaluated in clinic prior to a procedure. We review the patient's symptoms, the relevant labs, and review the patient's multi-phase chest CT with contrast. As all the sniper technique patients cases are performed under general anesthesia, all these patients are sent to the pre-op clinic in order to obtain clearance. It's important to understand the central venous occlusion anatomy. So a multi-phase chest CT venogram with good contrast resolution is critical. Just ordering a chest CT venogram might not have adequate opacification of the central venous system because of the central venous occlusion. So we also recommend, and we order all the time, an arterial phase as well, in addition to the venous phase, that will provide a good understanding of the correlation between the central venous occlusion and the surrounding structures, especially arterial structures. For example, during the recanalization of a chronically occluded SVC, the path is typically narrow and surrounded by significant structures such as the aortic arch, the right pulmonary artery, and the right lung. During the recanalization of the right brachycephalic vein, it is important to keep in mind the correlation with the brachycephalic artery and the lungs. The brachycephalic artery can be tortuous and can be on the way, and sometimes the right upper lobe of the lung can also be on the way as well, depending on the patient's anatomy. During the recanalization of the left brachycephalic vein, it is important to understand the path between the venous stumps. Typically, one is at the peripheral aspect of the left brachycephalic vein, or at the confluence of the left subclavian NIJ, internal jugular vein, and the other is more centrally located in the SVC or more central portion of the left brachycephalic vein. Frequently, this trajectory, as you can see in this CAT scan on the right lower quadrant of the image, frequently this trajectory is not straight. As you can see on this axial diagnostic CT, what it will require carefully advancement of the crossing wire, and sometimes the use of a curved crossing wire, or the use of a straight crossing wire with a semi-curved catheter in order to cross the occlusion safely. The right brachycephalic vein recanalization procedure seems to be straightforward, but one should always anticipate that the right upper lobe of the lung may change position during the respiratory cycle and be on the way of the crossing device. In this case, for example, as you can see in the video here, our crossing technique is done under expiratory breath hold in order to cross the lesion safely. As you can see, the patient's in inspiration, the lung is moving towards the trajectory of the crossing tool, and in expiratory is away from it. And that's why we did, and that's one of the reasons why we do this case is under general anesthesia, so we can have breath hold as needed. We also prefer to reveal multiple reconstructions of the chest CT to better understand the anatomy of the venous occlusion. Here's a typical case that can benefit from a sniper technique. There is a SVC occlusion surrounded by the aorta and the lung. As you can see, a pretty narrow path between the lung and the ascending aorta. Typical dialysis patient with a pleural effusion bilaterally. As you can see here, there's also a large azygous vein that works as an important collateral in central venous occlusions, and we should do all possible to prevent crossing this important collateral vein, the azygous vein, especially if you use cover stents. In an axial view, it's possible to see now the narrow space that I was mentioning before between the ascending aorta, as you can see, the right pulmonary artery, and the right lung. Typically, this narrow space to cross the SVC occlusion basically measures around 10 to 15 millimeters in diameter. And sometimes the right atrium is located more posteriorly in relation to the most cranial venous stump. That can be the superior aspect of the SVC or the confluence of the brachiocephalic veins. Especially in SVC recanalizations, it is important to understand the extension of the pericardium sac. It can go up to 4 centimeters cranially from what we call the SVC right atrium junction. So this junction here between the SVC and the right atrium, it goes up to 4 centimeters above that level. Therefore, in any SVC angioplasty, an accidental tear of the pericardium sac can occur. So we highly recommend to be prepared for pericardium sac drainage in all SVC occlusion cases, and we'll talk more about this in future webinars. And it is very important to make sure that the subxiphoid window is prepped and have, for example, pericardium tray handy in all cases of sniper technique whenever you recanalize the SVC. Here, a central venous occlusion, central venogram done through a dual simultaneous hand injection, injecting from the patient's arm and from the patient's groin, multiple accesses that clearly delineates the SVC occlusion. You also can see an extensive large azygous vein. The venous access were obtained, as I mentioned, from the brachial and from the femoral veins. And it's important to keep in mind that the pericardium recess can go all the way up close to the origin of the azygous vein. Another important technical detail is about stenting. In SVC recanalizations, we typically prefer to use cover stents to prevent cardiac tamponade. However, ideally, we should always try to avoid crossing the origin of important collaterals, especially the azygous vein or the contralateral brachiocephalic vein in case you are recanalizing brachiocephalic veins whenever you use a cover stent. In my opinion, one of the most challenging venous occlusions to recanalize is the left brachiocephalic venous occlusion. Observe how tortuous it can be this trajectory for the crossing device to cross the left brachiocephalic vein occlusion. As you can see, it's not a straight shot. And if you simply advance, for example, a colapinto needle, any other stiff back end of the glide wire, anything straight, stiff and straight, you are not going to reach the target. That's why we prefer to use, for example, a crossing wire instead. Here is a 3D reconstruction They also can be very helpful to understand whether the stumps are on the same plane in the mediastinum or not. Here's an example of image fusion. In this case, imaging was fused using the diagnostic venography performed at the beginning of the procedure and the real-time fluoroscopy imaging on the left, or DSA in the background on the right. So you can use the DSAs you can see on the right side of the screen as a background infused with the initial venogram, or you can use fluoroscopy, either way. Here an example of another application of fusion of imaging, which is called integrated registration. A good quality multi-phase chest CT with contrast is also important in case you want to perform fusion of imaging during the left brachycephalic venous recanalization procedure, for example, as you can see here. In this picture, you can see an integrated registration showing a CT arterial phase of a chest CT with contrast, with the fusion, with the COM-beam CT that was obtained from the patient while the patient was on the angiography table. It's possible to identify clearly in this image the crossing wire starting from the left distal or more peripheral left brachiocephalic vein, and also we can see clearly the 10mm snare placed in the most cranial aspect of the SVC. Here's the same integrated registration now in sagittal view, demonstrating the small retrosternal space, in this case measuring 11mm, where the crossing wire has been advanced through a small space between the sternum and the supraortic vessels. You can see the supraortic vessels here with very good fusion of imaging. Integrated registration also used in this case to check the progression of the crossing wire, as it can be seen here after it had crossed the supraortic vessel, now diving down towards the SVC where the snare was, serving as a target. Here, a coronal fusion of the integrated registration, showing that the snare already is already closed and the crossing wire hooked to it, and you're ready to do the body floss with the, we can pull the wire out and then exchange the crossing wire for something stiffer like an Amplatz, 260 Amplatz wire. It's important to plan ahead of the game and understand the anatomy well, especially in complex occlusions like in this case. This is a little bit different territory, a patient with absent infrarenal IVC. This patient was born without infrarenal IVC, and it is possible to identify an extensive collateral through the gonadal veins and paravertebral plexus. When using the sniper technique in IVC reconstructions, it is important to understand the correlation of the occlusion of the occluded venous tract with the duodenum, and potential tortuosities of the abdominal aorta that can get close to the tract that need to be crossed, and also need to check the level of the renal arteries. As you can see here, we have the IVC right anterior, for example, in relation to the renal artery. Always check the anatomy. So in this case, you can see how close the duodenal and the right renal arteries are to the IVC stump. You can see the IVC stump is right in this territory, and you can see the renal artery here, and you can see the duodenum crossing just anteriorly from where we need to be. Here, an example of a picture coming from above. You can see this is the right renal vein. This is the same patient, the same case. And you can see that we were able to navigate through the retroperitoneum just with a hydrophilic wire all the way to the stump. And we're using here a crossing wire using the sniper technique as a re-entry tool instead of crossing the entire retroperitoneum with a crossing tool. Here's a patient with severe right leg edema. Compare the diameter of the right and left thighs. Clearly see there's a central occlusion or iliac venous occlusion in this case. And this occlusion was secondary to a catheter that was placed for a long time in the right common iliac vein. and in the transition with the IVC. So both totally occluded. That's why this patient developed this massive edema. Also in complex iliac reconstructions, we can use a 3D model in order to understand the trajectory. So here, using a 3D model reconstruction, we're able to delineate the iliac artery, the iliac vein, and create a trajectory for crossing the vise. So you can see here, for example, you have in one picture the artery, one picture the vein. With the define both, you can see clots inside the vein here more proximally. The artery is widely patent with a little bit of calcifications. But then you can also fuse both and then create a 3D model to define exactly what is a trajectory that we need to cross. As you can see in this picture here, the 3D imaging shows the trajectory, which is the orange line that needs to be reconstructed immediately next to the right common iliac artery, as you can see in this 3D model here. So look how close we are to the artery. And this orange line is going to give us, in real-time fluoroscopy, is going to give us a trajectory where we need to go. And this certainly adds safety to the procedure. So in summary, we recommend the use of sniper technique whenever the patients are symptomatic and if the patient has malfunctional dialysis access. A chest CT with contrast is critical to understand the anatomy. Good pre-op images can also be used for fusion, as will be demonstrated in a few cases during the procedure, which will probably add value and safety to the case. And it's important to come up with a meticulous plan to minimize the risk of complications and, above all, be ready to manage complications in case they occur. So thank you very much for the opportunity to discuss with all of you a little bit about the pre-op aspects of the sniper technique. The next webinar on the sniper technique will focus on the case setup. We're going to talk about patient preparation, considerations in anticipation of complications, and the required tools such as catheters, wires, introductory sheaths, etc. And I hope to see you soon.